An endotracheal tube provides direct control of the airway and an open pathway for oxygen to be blown into the lungs. In some areas, EMTs are trained to perform endotracheal intubation, an advanced airway management skill. In other areas, only ALS providers are trained to perform this skill. Even so, EMTs may be asked to assist in inserting an endotracheal tube or to ventilate an intubated patient. In this segment, we will briefly review ventilating an intubated patient. When assisting an ALS provider, you will encounter several important pieces of equipment. The ET tube itself is a slightly curved, flexible tube with a hole at each end. The tubes come in different sizes, which are noted on the outside of the tube. Please note, images of the ET tube out of its sterile packaging are for demonstration purposes only. Testing and assembly of the ET tube must be performed with the tube inside its sterile packaging. The ET tube must remain in its sterile packaging until it is ready to insert into the patient. An inflatable cuff at the distal end of the ET tube seals the trachea and prevents aspiration. In most cases, the ET tube is used in conjunction with a stylet, a pliable metal wire typically coated with plastic. It is then used to form the tube into a hockey stick shape that aids in the tube's insertion. For instructional purposes, a training mannequin is being used for this demonstration. When inserting the ET tube, an ALS provider will place an illuminating device, called a laryngoscope, into the patient's pharynx and lift the epiglottis. This procedure provides for direct visualization of the vocal cords and the glottic opening, which in turn makes it possible to pass the tube into the patient's trachea. Laryngoscopes use two types of blades, a straight or Miller blade and a curved, also known as a Macintosh blade, and come in different sizes. To assist with ventilating the intubated patient, you will need the following equipment: BSI equipment, BVM with reservoir attachment, oxygen cylinder, suction unit and catheter, ET tube in proper sizes, stylet, laryngoscope handle, laryngoscope blades, both straight and curved, water-soluble lubricant, a 10 cc syringe, towel, esophageal detector device, an end-tidal CO2 detector or capnographer. Take BSI precautions. Position yourself at the patient's head. With the BVM attached to oxygen, ventilate at a rate of no more than 10 times a minute, or one breath every 6 to 8 seconds. Slowly squeeze the bag over 1 second for each ventilation, stopping when observable chest rise is achieved. ET tubes can be dislodged during additional medical procedures, while ventilating, or during movement of the patient. If you feel that the tube has been dislodged in any fashion, contact the ALS provider immediately. Never just push the tube back in place. You can cause the tube to transfer from the trachea to the esophagus, which, left unnoticed, will kill the patient. Constantly monitoring the patient's chest rise and monitoring capnometry if you have it is the best way to assess for dislodgement. A sudden drop in capnometry numbers could indicate that either the patient has gone into cardiac arrest or the tube has been dislodged. Take action or notify your ALS provider immediately if either occurs.